Welcome to the Explainer. Today, we're putting on our medical detective hats to decode a truly fascinating, yet often misunderstood condition, Sjögren's disease. We're going to move from the surface-level mysteries, those frustrating everyday symptoms, straight into its profound and sometimes downright dangerous systemic impacts. So let's jump right in and unravel exactly what happens when the body's own immune system suddenly turns against its moisture-producing glands. We're kicking things off with a staggering demographic hook. This disease predominantly strikes middle-aged women, outnumbering men by a massive ratio of 10 to 20 to 1. I mean, that's a striking imbalance, right? It instantly tells us that there are profound genetic and quite possibly hormonal drivers at play here. For any clinician, this is an absolutely crucial first piece of the puzzle. Here's our clinical roadmap for today's Explainer. We'll be looking at the sicca symptoms, diving into the autoimmune battleground, exploring extraglandular systemic impacts, addressing the lymphoma risk, and wrapping up with clinical diagnosis and criteria. Let's get right to it with Section 1, the sicca symptoms. What we're looking at here is a classic, severe case of xerostomia, profound dry mouth. The deeply fissured tongue you see reflects a nearly complete lack of expressible saliva. The tiny bumps on the tongue, the filiform papillae, have literally atrophied. Because of this, patients deal with a severe burning sensation, a huge spike in dental cavities, and, simply swallowing dry food becomes incredibly difficult and painful. But the dryness goes well beyond the mouth. Patients also experience keratoconjunctivitis sicca. Now, this isn't just your standard dry eyes. It's an intensely gritty, sandy feeling right under the eyelids caused by a profound lack of tearing. Without that crucial protective layer of moisture, the epithelial layers of the cornea and bulbar conjunctiva actually start to break down. This leads to painful ulcerations, severe light sensitivity, and the accumulation of these thick strands of mucus. And the domino effect doesn't stop there. This diminished exocrine function hits mucosal surfaces across the entire body. It can cause xerotrachea, basically a dry respiratory tree that leads to a persistent, nagging dry cough. It affects the gastrointestinal tract, triggering esophageal dysmotility and atrophic gastritis. It causes vaginal dryness, which leads to dyspareunia. And, kind of paradoxically, despite the severe lack of saliva, about 2/3 of patients will actually experience intermittent or persistent enlargement of their major salivary glands, like the parotids, simply because those glands become entirely packed with rogue immune cells. Moving on to Section 2, the autoimmune battleground. So here is the absolutely crucial takeaway. Sjögren's is not merely a disease of dryness. Fundamentally, it's an autoimmune epitheliotitis. What does that mean? It means the immune system is specifically locking onto and targeting the body's epithelial cells. Lymphocytes swarm around these tissues in massive numbers, and they ultimately force the glandular epithelial cells into increased rates of apoptotic death. They are literally being killed off from the inside out. Inside this microscopic battleground, it is absolute chaos. Infiltrating, highly activated T cells lead the initial strike on the glands, but joining them is a state of profound B cell hyperactivity. These hyperactive B cells act like factories out of control, churning out very specific autoantibodies, most notably Rho52, Rho60, and LA. And why is all this happening? Well, it's driven by distinct genetic risk factors. We see strong associations with the HLA-DQA1/O501 allele, as well as critical variations in the interferon and BATH pathways. It's almost as if the immune system in these patients is genetically hardwired to overreact. All right, let's head into Section 3, extraglandular systemic impacts. The complexity of these systemic impacts is immense, but we can break it down into 3 main categories to make sense of it. First up, nonspecific symptoms. Think deep, debilitating fatigue and a non-erosive arthritis that can easily mimic other autoimmune diseases. Second, we have periepithelial involvement. This is where lymphocytes go rogue and infiltrate organs like the lungs, causing bronchitis sicca, or the kidneys, resulting in interstitial nephritis. And finally, the third category, immune complex-mediated damage. Circulating antibody complexes actually deposit themselves in tissues. This triggers really serious issues like cutaneous vasculitis, which clinically shows up as palpable purpura, along with glomerulonephritis and peripheral neuropathies. This brings us to Section 4, the lymphoma risk. Now we need to pay really close attention here because the stakes are high. Out of all autoimmune conditions, Sjögren's disease carries the absolute highest risk for lymphoma development. This is a direct, profound consequence of that persistent B-cell hyperactivity we were just talking about. Specifically, these patients face a highly elevated risk for developing extranodal, low-grade, marginal zone B-cell lymphomas.
Because of this risk, clinicians have to be incredibly vigilant for specific clinical red flags that signal a patient might be escalating toward malignancy. Persistent parotid gland enlargement and palpable purpura, those are major warning signs. And when looking at blood work, if we spot low C4 complement levels, monoclonal gammopathy, or the presence of cryoglobulins, alarm bells should absolutely be ringing. These markers strongly suggest those hyperactive B cells are mutating and starting to proliferate completely out of control.
Furthermore, there are distinct histopathologic warning signs we can spot under the microscope. When a minor salivary gland biopsy is performed, seeing heavy focal lymphocytic infiltrates is pretty expected for Sjögren's. But if a pathologist sees the formation of actual germinal centers inside the tissue, which are structures that usually only belong in lymph nodes, well, that's a highly critical marker indicating the tissue environment is primed for lymphoma. Finally, let's cover Section 5, Clinical Diagnosis and Criteria. To diagnose this complex condition, we rely on the meticulously designed 2016 ACR/EULAR diagnostic algorithm, which acts as our definitive clinical roadmap. It all starts with the patient's subjective experience. Do they have daily, persistent dry eyes or a dry mouth that's lasted for more than 3 months? Are they constantly relying on tear substitutes? If those baseline criteria are met, the algorithm then requires us to combine those symptoms with some very precise, objective tests to firmly confirm the disease. To officially fulfill those criteria, clinicians have to execute a series of highly specific steps. First up, measuring unstimulated saliva flow. A rate of 0.1 milliliters per minute or less, that's abnormal. Next is Schirmer's test. This involves placing tiny strips of filter paper inside the lower eyelid to quantify tear production. If it's less than 5 millimeters of moisture in 5 minutes, that's a positive result. Third, they use an ocular staining score to reveal any actual cellular ulcerations right on the eye's surface. And finally, and this is often the most definitive step, they perform a minor labial salivary gland biopsy. They're looking for a focus score of 1 or more to confirm those dense lymphocytic infiltrates we touched on earlier, all while checking the blood for those specific Rho autoantibodies.
However, getting an accurate diagnosis strictly requires ruling out a bunch of mimic conditions. We absolutely cannot diagnose primary Sjögren's if the sickest symptoms are actually the result of past radiation treatment to the head or neck. We also have to rule out active hepatitis C, HIV, sarcoidosis, and IgG4-related disease. We have to be completely thorough to ensure the symptoms are truly being driven by the unique autoimmune epithelioid nephritis of primary Sjögren's.
As we wrap up this explainer, we're left looking toward the horizon. If we can map out the exact genetic vulnerabilities, like those specific HLA alleles, and track the cellular anomalies that drive this disease and predict lymphoma, it begs a really powerful question. How close are we to developing early interventions and targeted immunotherapies that can stop this autoimmune epitheliitis in its tracks before the irreversible tissue damage even begins? It's an absolutely fascinating frontier in rheumatology. Thank you so much for joining me on this deep dive today. Keep questioning, keep learning, and I'll catch you next time.